And moving to our next speaker, please allow me to welcome and introduce Professor Hala Izzat. Professor Hala is a professor of anesthesiology and surgical intensive care and pain medicine, Qasr Al Aini, Cairo University, Egypt. Today, she will shed some light on the anesthesia for robotic surgery. Professor Hala, the floor is yours.
Okay. Thank you. Our topic today will be anesthesia for robotic surgery. Does it need special skills? Actually, our objectives, we are going to go through a new subspecialty, and we are going to know what is the surgical robot, what are the advantages of robotic surgery over laparoscopic. Actually, many operations can be performed using a robot with a quite successful results up to pediatric surgery. The anesthesiologist, sorry to say, is confronted with many challenges till the post-operative period. The robotic surgery has been grown by its own subspecialty. Many operations can be performed using this technique, like urologic cholecystectomy, thoracic, cardiac, transoral, pediatric. It represents a great challenge to the surgeon as well as to the anesthesiologist. What is the surgical robot? The robotic system now presents three-dimensional views with magnifications and tools with 7 degrees of freedom that are capable of duplicating hand movements with very high accuracy. There are many of them. Most popular are the Da Vinci system, the C and Zeiss. The Da Vinci robotic system consists of 3 parts: the surgical cart and the optical 3-dimensional vision tower and the console. The surgical cart has 4 arms that can be manipulated by the surgeon in a console through a real-time computer-assisted control. The first 2 arms represents the right and the left arms of the surgeon. The third arm positions the endoscope, and the optional 4th arm enable the surgeon to hold another instruments to perform additional tasks, such as holding, counteraction, and following running sutures. Thus, this eliminates the need for a patient side surgeon. The surgical cart actually is heavy and bulky, and because of its proximity to the cart to the patient must be guarded against inadvertent contact due to motion of the robotic arms. I write this at the end. We cannot see the anesthesiologist in the scene. The anesthesiologist is completely far away from the scene. This is another demo, and this is the console, the surgical cart, and the optical 3-dimensional vision tower. And again, the anesthesiologist is not in the scene. Basically, robotic surgery offers the benefits of laparoscopic surgery, like improved cosmosis, reduced post-operative pain, faster recoveries, shorter hospital stay. And besides, the robotic surgery also overcomes the shortcomings of conservative laparoscopic or endoscopic techniques, like it is transmitted from assistant-dependent unstable video camera to a fully controlled surgeon, from 2-dimensional view to 3-dimensional view, from restricted ergonomics of the surgeon to a possibility of remote site surgeries. The instruments with the limited degree of freedom to an easier instrument manipulation, from the absence rest gear to a duplication hand movements with very high accuracy and 7 degrees of freedom, up, down, side to side, forward, backwards, rotation around a central axis. What is the role of the anesthesiologist? Actually, the anesthesiologist is confronted with many challenges. First, the patient's position: Trendelenburg, reverse Trendelenburg, lateral and lithotomy, pneumoperitoneum with prolonged surgical time, all affects the hemodynamics and ventilation of the patient especially in a compromised old patient. There may be a consequential nerve injury from this position. All are quite usual, but what if you are standing far away from your patient? For example, the accessibility for upper abdominal and thoracic surgery, they are done with the OR table rotated 180 degrees away from the anesthesiologist, with the robot positioned cephalad above the patient. For mediastinal procedures, they require the OR table to be rotated 90 degrees away from the anesthesiologist. During these cases, access to the patient's airway is nearly impossible. Thus, the avoidance precautions must be exercised beforehand. The challenge also comes if one lung ventilation is required and sometimes frequent fiber optic bronchoscopy. This is a demo of the surgical cart in a cephalad position. And here is the patient. All the lines are very long to reach this anesthesiologist and his anesthesia cart. He's very far away from the patient. Now, what are the perioperative challenges for the anesthesiologist during robotic assisted surgery? Besides the general considerations like cardiovascular, pulmonary comorbidity, it is very difficult to access the patient. Also, the steep Trendelenburg and the anti-Trendelenburg position is a challenge. Prolonged pneumoperitoneum, how to maintain body temperature, how to give fluid management, how to maintain pain management. The teamwork and the communication actually is very, very important in these situations to combat complications. Upper body edema can occur with the Trendelenburg position. There is a possibility of post-operative visual loss, peripheral nerve and soft tissue injuries, cardiopulmonary compromise. There may be also pneumothorax and the pneumomediastinum up to venous air embolism. Hypothermia from a prolonged procedure and occult blood loss. This is the usual Trendelenburg position. And as we can see, the inclination of the patient is only 10 to 15 degrees down. But for the steep Trendelenburg position, the inclination reaches up to 45 degrees. Now, what are the physiological the changes and complications of pneumoperitoneum in the Trendelenburg position? Cardiovascular system, there is actually increase in systemic vascular resistance, mean arterial pressure, central venous pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, and myocardial oxygen consumption. There may be increase or decrease in cardiac output and cardiac index, and also increase or decrease in heart rate. There is decrease in renal portal and splanchnic flow. Concerning the respiratory system, there is increased ventilation perfusion mismatch, increased peak airway pressure, but there is decrease in the functional residual capacity, of course, from this bad position, steep Trendelenburg position, decreased vital capacity, decreased compliance by up to 50%. There is also an incidence of pulmonary congestion and pulmonary edema, hypercarbia, and respiratory acidosis. The central nervous system, there are increase in all parameters like increased intracranial pressure, increased cerebral blood flow, increased intraocular pressure up to 15 millimeter mercury, and we have to be very cautious in glaucoma patients. Endocrinally, there is increased catecholamine release and activation of the renin-angiotensin system. For other changes, there is gastroesophageal regurgitation, very high incidence, decrease in total hepatic blood flow, mesenteric blood flow, renal blood flow, and gastric pH. There is a great incidence of subcutaneous emphysema, pneumothorax, pneumomediastinum, venous air embolism. Also, neuropraxia, especially brachial. There may be ischemic optic neuropathy, corneal abrasions from the leakage of the gastric acid on the face. Tracheal tube may be displaced and due to shortening of the trachea by about 1 centimeter. There may be also facial and airway edema. Now, how to control on how to know the cause of increased CO2. The maintenance of normocarbia and acid-base status is also challenging, especially in patients with poor preoperative respiratory conditions. The main factors like increased peritoneal absorption of CO2, increased dead space, especially in patients with coexisting respiratory disease, increased metabolism, inadequate ventilation, that is a fault by the anesthesiologist, subcutaneous emphysema, and or CO2 embolism. For preoperative medication, it is mandatory to give low molecular weight heparin before surgery to guard against deep venous thrombosis. Oral ranitidine is very also mandatory to decrease the gastric acidity, laxative suppositories to improve the visual field. For induction, we can use the standard IV induction agents, but we have to adjust the anesthetic plan according to the patient's condition. But we have to know that the endotracheal tube should be taped securely, appreciating that the patient position may alter the tube position over time, leads to unintended extubation or main stem intubation. Robotic instruments may dislodge the tube, exacerbated by an obstructed view. So for replacing of an endotracheal tube would be challenging based on positioning and the time delay until undocking of the robot. For maintenance, as the procedure is a lengthy operation, we can use volatile agents with a favorable recovery profile like desflurane or sevoflurane. Many institutions choose to run a background infusion of remifentanil. The patient must remain paralyzed all through the operation until the robot is completely undocked at the end of the procedure, usually with a continuous infusion of non-depolarizing neuromuscular agent like cisatracurium or atracurium. To guard against hypothermia, a warming overblanket should be applied to the upper torso, and because hypothermia is due to prolonged pneumoperitoneum with dry cold gases. Any lines, monitors, and patient's protective devices must be placed before hands and should be secured to ensure no kinking or displacement. This is very important because we cannot reach the patient at any time during the operation. It is important that the anesthesiologist is especially rigorous in ensuring that there is no pressure in vulnerable areas, especially the elbows, the axilla, back, and shoulders by using special pads. Additionally, as we said, no type of movement is allowed during the operation because any movement while the robotic instruments are docked could lead to tearing or puncturing of the internal organs or leads to potentially devastating consequences. The pulse oximeter probe should not be positioned on the ear because of the potential erroneous readings due to high venous pressure in the earlobe. This is induced by the Trendelenburg position, severe oral ulceration, and the conjunctival burns may be caused by reflux of the stomach acid into the face during the procedure. And there are special covers and pads can be used, but also this is a challenging because it is difficult to remove this in emergency situations. If the patient remains hemodynamically unstable or hypoxemia is resistant to the application of PEEP, the operation at this time have to be abandoned or converted to an open procedure. The position of the robot may interfere with the effective cardiopulmonary resuscitation and airway interventions. So we need within 30 seconds. It must be possible to deliver a DC shock with even the robot is docked in position if required. It is aided by the addition of audio speakers to the video tower that transmits the operating surgeon's voice. Concerning gas embolism, for gas embolism, we have to rapidly remove the pneumoperitoneum, hyperventilate the patient with oxygen, placing the patient in the left lateral decubitus position with the Trendelenburg position, and aspirating the embolus via the central venous catheter. In case of severe gas embolism with cardiovascular collapse, resuscitation is restricted due to docking of the robot. The surgical team should practice the emergency drill for de-docking the robot system if necessary to prevent a delay in resuscitation, or sometimes the DC shock may be applied with the robot is in place. For one-lung ventilation strategies, they prefer to use during surgery the inspired oxygen, FiO2 at 1, the airway pressure kept below 30 centimeter water, begin one-lung ventilation with pressure-controlled ventilation. The ventilation should be adjusted to maintain partial pressure of carbon dioxide around 40 millimeter mercury, and this is aided by the serial blood gases, application of PEEP to the dependent lung, or application of CPAP to the non-dependent lung may assist in oxygenation. Anesthetic challenges also, again, there is spatial restrictions due to the bulky equipment. It is a universal issue. So after the robot has been positioned and engaged, the anesthesiologist is quite unable to readily access the patient. Thus, it is impossible to allow any changes in the patient position or any kind of access to the patient if the robot is not detached first, because this time delay in patient management may in complications, especially in unhealthy patient or pediatric cases, early detection of any problem. That's why the anesthesiologist has to be very rigorous and always in attention. The anesthesiologist and the training of the surgical team for the fast detachment of the robotic system in emergency situation. The anesthesiologist should give attention to the robotic arms, very important, and the patient position to prevent pressure or crush injuries. How to overcome the drawbacks of Trendelenburg position to the lungs? Tidal volume is used from 6 to 8 ml per kg. Positive end expiratory pressure PEEP of 47 are recommended for prevention of atelectasis. Maximal airway pressure should be kept under 35 centimeter water. Pressure controlled ventilation actually is preferable than volume controlled ventilation because it results in a greater dynamic compliance and lower peak inspiratory pressure. They used a prolonged inspiratory duration that can be an alternative to producing better gaseous exchange, like inspiratory to expiratory ratio of 2 to 1 or 1 to 1, provided better oxygenation and lower PaCO2 levels than the conventional 1 to 2 ratio by preserved dead space to tidal volume ratio in the steep Trendelenburg position. The combination of the steep Trendelenburg position with the CO2 pneumoperitoneum can reduce the length of the trachea. The distance from the vocal cords to the carina would be reduced by 1 centimeter compared to pre-positioning, and this may lead to either extubation or main stem intubation. The tube may go to the brainstem bronchus stem. Because CO2 readily permeates into the bloodstream, the resulting hypercarbia may cause sympathetic stimulation, and this may lead to increased heart rate and blood pressure. How to adjust the patient's position? In Trendelenburg positions, the patients are prone to sliding off the table. Of course, we can see it is very steep, but the shoulder braces can cause brachial plexus injuries. Therefore, they use the technique of strapping the patient to the operating table with chest bending. This technique is advocated. However, this method can aggravate more the decrease in the lung compliance. This position can also injure the upper extremities by causing peripheral nerve injuries. In some institutions, they prefer to use combined thoracic epidural anesthesia with general anesthesia, and they claim that this leads to a lower peak inspiratory airway pressure, enhanced dynamic compliance, allow better oxygenation, gives a lower concentration of lactate through the muck, and having a systemic stabilizing effect on the neuromuscular junction by the local anesthetics, and also attenuating the bronchial hyperactivity. Concerning the fluid management, it is another challenge because the trend is we give mildly restricted fluid management is required for less facial edema and decrease the excessive urine output that could obscure the operation field. That's why they give no more than 800 ml of fluids can be given until the surgeon completes the vesicourethral anastomosis. And this is followed by infusion of additional 700 or 1,200 ml of fluids. In the post-operative period, these patients require rigorous attention to the kidney and to the hemodynamic conditions. That's why the patients requires fluid boluses to support not only the urine output, but also to maintain normal hemodynamic parameters. At the end of the operation, for the emergence from anesthesia, the robot has to be removed first from the patient, and then we can reverse the neuromuscular blocking. Although some concern has been expressed regarding the slow wake-up secondary to cerebral edema that may occur from prolonged Trendelenburg position. In the immediate post-operative period, there may be ileus secondary to pelvic hematoma or anastomotic leakage. Blood transfusion is usually not required because the intraoperative blood loss is very low, but significant hemorrhage may occur and it may be insidious, and the patient should be carefully monitored in this period. Compartment syndrome in the calves after prolonged lithotomy, and the patients should be routinely checked for calves tightness and tenderness until discharge. How to deal with special considerations in obese patients. The patient height and weight should be carefully considered as obesity BMI above 30 may be accompanied by physiologic changes like obstructive sleep apnea, restrictive pulmonary disease, difficult intubation, emptying, difficult vascular access can occur, very common. Comorbid conditions like cardiovascular or diabetes. Obese patients may be at increased risk for conversion to open or aborted procedures. So for precautions, we can use the least degree of Trendelenburg position and ensure the shortest duration of the steep Trendelenburg position. And we have to guard against rhabdomyolysis that may lead to renal failure, obstructive sleep apnea or obesity hypoventilation syndrome. So we have to consider post-operative CPAP as appropriate. For post-operative analgesia, multimodal analgesic agents can be used, including acetaminophen and non-steroidal anti-inflammatory drugs if they are not contraindicated. A small percentage of patients require opioids, very small. This school is against epidural analgesia because they said that there is a sparse evidence of any benefit, especially for the early discharge of the patient. If the epidural catheter is placed, they claim that it should not be used intraoperatively as the steep Trendelenburg position can cause high block and increased cardiovascular instability. So our aim is clear. We have to describe the anticipated concerns associated with the robotically assisted procedure and effectively create an appropriate differential diagnosis for the obese patients in the steep Trendelenburg position with markedly elevated airway pressure. We have to describe the factors that should lead to, for example, disengagement of the surgical robot and the steps required and the common complications associated with the use of the surgical robot. And we have to develop and demonstrate the necessary technical and behavior skills that we have to manage any intraoperative crisis. Before I finish and say thank you, I brought some demo photos of the different patients' position. This is the lateral position for robotic surgery. It is done for nephrectomy, pulmonary resection, lateral liver procedures, and distal pancreatic procedures. Robotic gynecological procedures, position for pelvic procedures, and the position for procedures with the Da Vinci against the Z surgical system. It is claimed that most procedures with the Z can have the head and the airway of the patient under complete control of the anesthesiologist. And this is that we have used in our presentation. And this is used for hepatobiliary gastric and anterior thoracic surgery. Thank you again.
Thank you very much, Professor Hala. That was very comprehensive. Got a couple of questions for you here. So the first question, do you think robotic surgery should be incorporated into the ERAS protocol by replacing conventional lab procedures? ERAS protocol is the Enhanced Recovery After Surgery protocol.
Enhanced recovery.
Yeah.
Of course, this can be done by using very minimal remifentanil. It is run through the operation time, and opioids not preferred to be given for the patient, and this also enhances the post-operative recovery. And that's why we use very cautious drugs to control the post-operative period of the patient for the early discharge.
Okay, thank you for that. Next question, what is the incidence of post-operative visual loss after robotic procedures?
I don't have a figure or a number, but there are precautions against this by decreasing the acid, the gastric acidity by giving antacids for the patient preoperatively. And there are special pads for the face and the eyes to protect against leakage of the gastric contents to the eyes and the oral cavity of the patient. But a figure of percentage or incidence, I don't know actually.
Okay, thank you. Next question, as the surgical time concerns, do you think a system for surgical learning curve is needed, which means when to be under supervision or alone?
Of course, there is an assistant in the OR theater. He is present, but he is not allowed to interfere until it is needed at any time. Just to help for the docking of the robot or detachment or for any emergency, there must be an assistant surgeon near the patient.
Okay, thank you. Is it needed to have a prefixed adhesive DC pads which can help if needed?
They said that it protects the face and the eyes, but in emergency situation, they said also that it is difficult to be removed during emergency. For example, for the tube is extubated. We have to remove many things to reach the tube. That's why it has benefits and drawbacks.
Okay, so you would go with having DC pads placed?
I think.
All right.
You mean DC?
Yes.
No,
the DC
sorry,
pads.
sorry.
No,
DC pads are, I am sorry, I heard about the pads around the face.
Let me read the question
The
again
DC
for
shock
you.
pads can be placed beforehand and secured also for any emergency use during the OR duration. Okay. I'm sorry, I didn't hear well.
No, that's absolutely fine. Last question, can the LMA help in case of accidental extubation till we can re-intubate the patient? So if you get an accidental extubation while the robot is still docked in, yes. I believe the colleague is asking, can we use an LMA to secure the airway potentially until,
it is difficult to use the laryngeal mask because the position of the patient is Trendelenburg position. Also, we can use it if it is very emergency, but the surgical team and the anesthesiologist, they are trained many times for any emergency, and they have to deal with any emergency immediate. That's why they not start proceeding for the operation before simulating many emergencies before going with actual patient.
Okay, thank you. How to decrease hypercarbia in obese and steep in obese patients in steep Trendelenburg in robotic surgery?
It is very difficult, of course. That's why we said that the procedure may be abandoned if the patient has cardiopulmonary compromise or resistant hypercarbia or even hypoxemia with the PEEP. All of this, we have to abandon the procedure or turn to an open procedure. And we have to explain this to the patient beforehand. Okay,
thank you. When would you insert an arterial line?
Yes, I read a lot about this concerning the arterial line. They said that it's not mandatory. I don't know why. Maybe because you cannot reach the patient or you cannot adjust the level accurately. I don't know. They do not prefer using as a routine the arterial line. Okay. As a routine, but it may be used in critical patients, of course.
Maybe in selected cases. Okay. Thank you very much, Professor Hala.